And the next speaker now will try to connect. You have heard him a little while ago, Dr. Hasitha Tissera. He is the head of the National Dengue Control in Sri Lanka. And I'm sure he will tell us whether or not dengue came down or went up in Sri Lanka. But definitely, we are in for a more picturesque march towards the future. What is in store for the future with dengue? So without further ado, let me call back my good friend, Dr. Hasitha Tissera, to let us lead the march towards ending the neglect for dengue. Dr. Hasitha?
Thank you so much. Wish to thank the organizers for inviting me to give this final talk on a very interesting 3-day seminar that was held to commemorate the ASEAN Dengue Day. And a special appreciation to Professor Lulu Bravo. I think amidst the 2 speakers from the Philippines, I was chosen by her to give this final talk. Well, I'm really appreciative of her choice. And Madam Chair, you gave me the liberty to choose a title which I thought was suitable to end the session and the overall seminar itself. My slides might appear a bit heavy, for which I apologize from the audience in advance. It was done somewhat intentionally to allow you to read them leisurely as time permits if you wish to, and for me to tease out the key messages during the talk. Dengue is an old disease with wide distribution of the condition in tropics and subtropical areas for over 200 years. During World War II, dengue fever was a major cause of morbidity among Allied and the Japanese soldiers fighting in Asia and Pacific war zones. First reported epidemic, as Professor Lulu just alluded to, of DHF was in Manila in the Philippines in 1953 and 54. And the second one was in 1956. And there was a third epidemic, which was reported in Bangkok, Thailand in 1958. After that, DHF was gradually spreading to other Southeast Asian countries as well. And a secular trend, as mentioned by the first speaker, was observed with epidemic activity every 3 to 5 years in those countries. Prior to 1970, there had been only a handful of countries in the world which had experienced DHF, and they are highlighted in this cartoon of mine. The case fatality rate, or CFR, from 1956 to 1995 reported to the WHO regional office are summarized in this slide. The CFR, or case fatality rate, can be used to estimate the proportion of DHF, the more severe form of dengue, and to see how severe the disease is spreading. Most countries reported mixed DF and DHF cases, and the proportion of the two syndromes, if you were to call them, varied widely between countries and between seasons. Despite high prevalence of DHF, with good clinical care, the CFR has come down in most of the countries over the years. Mark Beatty from the Pediatric Dengue Vaccine Initiative of the International Vaccine Institute in Seoul, Korea, in 2010, estimated that the global burden was in the tune of 36 million cases per year. It is also thought that as many as 1 in every 100 people are infected with the dengue virus each single year. Based on statistical modeling, it was estimated that in over 100 countries of these infections, over 2 million DHF cases are seen annually. It was also estimated that around 21,000 deaths are likely to occur due to the severe form of dengue or DHF annually. Subsequently, more recently, I would say, Zheng and colleagues in 2021, incidentally from Wuhan, China, have estimated that the age standardized incidence rate increased from 430 in 1990 to 1,370 per 100,000 by 2017. They also estimated that the deaths due to dengue increased from 16,000 in 1990 to 40,000 plus in 2017. In 2019, WHO named dengue as one of the major threats to global health. We know that the morbidity, especially mortality, is more in Asia, while Latin American countries report a large number of cases, but still with low mortality. If you take Asia, it bears 70% of the global burden of dengue. India alone estimates to a significant contribution of that burden. ASEAN countries, as mentioned previously, the dengue situation has not showed any slowing down. If you look at 2019, the year before the COVID pandemic engulfed the globe, there were a significant number of cases reported from the major contributors to ASEAN. Most endemic countries are experiencing challenging situation due to the epidemiological changes that we see in dengue today. There is a clear shift in the reported age towards adults in many countries, together with more complications and deaths among adults. It might be partly due to the comorbid conditions that adults usually have, leading to more severe disease which are challenging in clinical settings with limited facilities in Asian region. Due to hyperendemicity, meaning co-circulation of all 4 serotypes of dengue, there is a predominant virus always, which usually predicts the major epidemics in the world. For an example, the unprecedented epidemic that we saw in Lahore, Pakistan in 2011 was due to the cosmopolitan dengue virus 2. In addition, primary vector mosquito Aedes aegypti is getting well established in suburban and rural areas with limited health facilities to manage complicated dengue cases. At the same time, the changes of urban environment due to rapid urbanization and global travel and trade, and the growing population density is causing a strain on the service provision and capacity. Today, implications for effective control of dengue is more challenging than ever before. Therefore, in 2012, the World Health Organization put out a global strategy to overcome these challenges and to have a sustainable universal approach. It was expected to reduce the burden of dengue with 2 specific objectives and several key strategies that are highlighted here in this slide. The 2 objectives were to bring down the mortality by 50% and the morbidity by 25% using 2010 as the baseline by 2020. Have we achieved that? I will now quickly go through those 6 strategies that are given on the right side of my slide, highlighting where we should be going from now with key messages to move forward. Taking surveillance, particularly integrated surveillance, which is a difficult topic. In Asia, there is a wide variety of country capacities. There are certain countries where dengue is a reportable disease from national point of view, whereas there are other countries where only outbreaks are reported. In non-endemic areas, many cases don't even get reported. The disease classification remains a debatable subject. I'll come to that in the next few slides. Information on circulating dengue virus serotypes are well established in many countries and many regions. Population level sero surveys, particularly important to know the burden of disease, are performed only selectively in most countries. Limited capacity to perform new assays, the PRNT assays, is non-existent in most countries. Priorities vary between long-term and short-term diseases. The long-term diseases being, for example, TB and such diseases, and short-term diseases being dysentery, typhoid, etc. So if you look at the right-hand side, the cartoon that is given as options for integrated surveillance, sky is the limit. There are many options that are available for you to choose from, and most of them are important. So there isn't a single country which actually pitches into all these activities. So therefore, surveillance, which is kind of the key cornerstone for dengue control and prevention, is still growing in its capacity. If you take the diagnosis and clinical management, there is still a debate. Harmonizing the best clinical practices is going to save lives. Here I'm showing a picture of Professor Suchitra Nimanith, whom we know for her single-handed bedside capacity, clinical skills in defining dengue hemorrhagic fever and identifying the point at which dengue hemorrhagic fever is a problem and finding the cure or the treatment for dengue hemorrhagic fever in a timely fashion when the technologies were not available many years ago. So still the debate is continuing, with the Southeast Asian region having their own guidelines and the global TDR guideline, which was issued in 2009, coming up with their own diagnostics and clinical management ideas. Still the debate continues, and so there isn't a harmonized way of managing dengue for that matter. So I won't go into detail of the classical and the TDR classification differences in diagnosis and clinical management. There seems to be a real need for harmonizing these two entities so that the peoples that we treat and manage will get a better deal. If you look at the global map for Aedes mosquitoes, particularly Aedes aegypti and Aedes albopictus, there is a very alarming situation. Globalization, travel, trade, demographic trends, and the warming temperatures are associated with the spread of mosquitoes. So this is a model that has been created, which gives a projection of the climate change affecting the areas where the mosquitoes will spread to from the current boundaries or borders in 25 years from now, and it's alarming. So urbanization, travel and trade, and global warming for that matter will certainly contribute negatively for sustainable vector control, and it'll be more challenging. In fact, I was in the Kingdom of Bhutan for an external review in 2019, and it was the month of December, at an elevation of 7,000 in the district called Punstaling. The container index ranged from 0 to 39, and these kind of high-rise buildings that is shown on the right-hand side of the slide were not uncommon in that area bordering it was in the southwest of Bhutan, which is a very small country, and it was bordering India. So this is the situation in terms of the challenge for vector control, and so we need to take note of this growing challenges due to things that we can probably look into in the bigger picture. Vaccine implementation is another challenge that we've come across over the years. And in fact, only 3 vaccines are in the advanced stages of pipeline. And I think we spoke about Dengvaxia, the Sanofi vaccine, which is registered in some countries, but it is not moving the way it is anticipated. And Takeda vaccine is coming to their advanced stages of the clinical trial, and they are proposing another dose for the vaccine. And the NIH Butanta vaccine is still in phase 3 trials, and there are hiccups due to the Zika situation in Brazil and the South American region. And the question that was posed by this gentleman, Professor Scott Halstead, who was spearheading in developing the PDVI organization way back in the 2000s, still remains to be answered. He says, to show that dengue vaccines protect humans against infection or disease caused by each of the 4 dengue viruses, and that the vaccine themselves do not directly cause symptoms in the vaccinated subjects or provoke other safety problems, remains still to be answered. So that's where we are with the vaccines, but it's a slow movement. So we need to really jack it up and look for a collective ways of moving forward with the vaccine programs for dengue, if at all, if it were to bring, better times related to the vaccine implementation. This is an interesting slide. On the left-hand side, a global meeting way back in October 1964 in Bangkok, Thailand, which was possibly the largest gathering of experts at that time. And the 2 professors that I mentioned earlier, Professor Scott Halstead and Professor Suchitra Nimanit, were part of this the program. They are standing in this group photograph, and this group met to identify ways in which research can be moved forward to bring about a lasting solution, a sustainable solution for dengue. And on the right-hand side, the pediatric dengue vaccine initiative, which was established in the capital of South Korea, in Seoul, in 2000s, had a consortia of clinical site field sites established both in the Americas and in Asia, and they really were doing a fantastic job way before the vaccines were piloted, and those sites were prepared in line for future vaccine trials to be implemented. So the key message here, as of 2021, do we have champions to take dengue research forward? So we are in search of champions who can really take dengue research forward. Advocacy and political commitment. This is another nightmare. Countries swing back and forth as dengue is perceived as a seasonal problem in many countries. So there is no commitment in terms of advocacy, and especially among politicians, to give a lasting thought for dengue in many countries. Very limited international advocacy funding efforts have come forward over the years. And we need a global advocacy effort and leadership for that matter to address dengue as a communicable disease, global communicable disease. Regional initiatives like ASEAN Dengue Day has really capitalized over the years. And I remember coming to Singapore for the first ASEAN conference somewhere in the early parts of this decade, and the commitment from the politicians from around the ASEAN countries have been conflicting, and so therefore we really need a special advocacy campaign involving multi-sectoral approach. And if you look at the costs are unbearable. Globally, different countries have estimated the cost for dengue in different ways, and still the numbers are really soaring. If you look at what happened in Sri Lanka in 2012, where there wasn't a big epidemic, it was relatively a marginal epidemic. The costs for public health, the public health costs were in the tune of $3.45 million US, and per capita, the cost was $1.5 US per capita. And managing dengue is not cheap. You need a lot of money, resources, and commitment to manage dengue. So for children as well as adult management, the countries will have to bear a lot of costs in the management when it comes to dengue. And if you look at the more advanced diseases where the global commitment has been forthcoming, for example, malaria. If you look at the two diseases, and see how they behave. Things seem to be changing. Malaria, which was a disease of the poor, quote unquote, as mentioned by particularly economists, seem to be on the decline in terms of numbers at least, and the countries that are affected. And on the contrary, dengue is on the rise. We really don't know the real burden, global burden of dengue, because it's still a difficult disease to negotiate with because of the wide spectrum of infection outcome in dengue. And the other challenge, which is now seen by the entire world, is COVID-19 versus dengue. Now, there are certain similarities and differences between the two diseases, but look at the commitment that COVID-19 has got. By 2021 June, there is a cumulative caseload of 176 million and a cumulative death toll of 3.8 million. And of course, the commitment has been forthcoming because of this grave situation. And can we use this platform and opportunity to roll out the control activities for dengue and COVID in tandem, is something that we'll have to think through, because that will really give us an opportunity to move forward in a more holistic manner. And finally, we need to change. The paradigm has to change, and advocacy for dengue for a World Dengue Day is felt more than ever before. Dengue has been a neglected tropical disease for over 50 years, I would say. And should dengue continue to be so for the next decade? I don't think so. Together, we should make a concerted effort and a voice for a global march towards ending neglected dengue and try to find solutions for this menace that is plaguing our countries, both in Asia as well as in the Americas. Thank you very much for this invitation. And these are my acknowledgements. And I'm happy to take any answers during the question and answer session. Over to you.